Welcome to Artificially Intelligent Risk Adjustment for Social Factors, presented by Lisa Lyons, Senior Health Services Researcher at RTI International. RTI has been a trusted partner in CMS's Medicare and Medicaid innovation efforts for many years, designing, implementing, and evaluating multiple accountable care organization models, alternative payment models, and episode-based payment initiatives. Through strategic and analytic thought partnership, RTI helps CMS finalize and implement policies, including most recently those related to the COVID-19 public health emergency. We also lend expertise in quality measurement, risk adjustment, health IT standards, and data analytics and science. The project Lisa will discuss today is just another example of RTI's commitment to bringing innovation and thought leadership to CMS.
Hi, thanks for joining today. I'm happy to be here to share a little bit more about our project. Many of us have heard about what are the determinants of health and how these determinants interact to result in health outcomes. And clinical and genetic factors are roughly 10 to 20% of what explains health outcomes. So the real influences on health are the behavioral factors and social factors. And those typically are not included or considered in a lot of the risk adjustment that's done today. So our project, RTI Rarity, is focused on capturing these social and behavioral factors to better adjust and measure and adjust for those factors in healthcare. So our analysis is based on geographic levels, several different geographic levels. I'll talk more about that on the next slide. When we think about geographic levels, the typical smallest unit of analysis would be a census block group. And you can get at census block groups with 9-digit zip codes. There aren't very many data elements that are available at the census block group level, but that is one of the smaller units of analysis. And you can see here in our example from Aurora, Colorado, block group on the far left, only about 1,400 people in a block group. On average, there are about 4,000 people in a census tract, and that's our base unit of analysis for our project. You can see that if you go up to the 5-digit zip code level, you have an order of magnitude larger number of people in that zip code tabulation area, or ZICTA. But that is another area level that we often see data coming in at that available level. The other level that we see a lot of data is county level. And so moving between these different geographic areas, you can see you are making observations about a lot larger number of people when you get to the county level. And sometimes that's the best that we can do, but obviously making an estimate that is across that many people is not as informative as when you can make estimates at a smaller level of geography. So our local social inequity scores are a measure that explains health outcome disparities or inequities in small geographic areas, chiefly the census tract, although we also have the scores available at the zip code and county levels. And we're using predictors related to social and behavioral factors. So our conceptual framework began with the Healthy People 2020 domains for social determinants of health. And those are listed on this slide in bold: education, healthcare, social and community, economic, and neighborhood. And we expanded the social, economic, and neighborhood domains into additional domains to get more nuance and to dig further into those domains. You can see we cover community health, bias, stress, and trauma, sorry about that, justice, crime, and incarceration, food security, access to healthy food, poverty, housing, environment, transportation. So from that conceptual model, we went to data curation, and that's where we used a hybrid approach, both application programming interfaces or APIs and downloaded data. It was a massive effort across over 2 years with over a dozen different staff with lots of different backgrounds and training and experience and lived experience, a very diverse group. And that's really important when you're doing this kind of research. So the data curation process, we gathered together data, and I'll talk more about that soon in a moment. Gathered data on everything that we could think of that might be related to our outcome, which was life expectancy at birth. And from there, we developed random forests for each state and DC, and then random forest across all of the US. And then from the random forest, we can develop these ranked percentile scores on a 0 to 100 scale. On the left, you can see the federal data sources, different agencies that contributed. As I mentioned, the USA LEAP project gave us our life expectancy estimates at birth. Those were released in 2018 for the first time at the census tract level, giving us a very good base on which to model. Many other US agencies, government agencies contributed data. All of this is public data, open publicly available data. On the right are some of the other data sources, including the Opportunity Atlas project, other county health rankings, the Child Opportunity Index, food insecurity data from Mapping the Meal Gap. So a lot of different data sources, over 150 different measures, and all of that data are curated, made into population-based rates, geocoded, spatially explicit. So a massive undertaking. Here you can see a graph showing all of the census tracts in the US. Each dot is a census tract. And on the left axis is life expectancy at birth. And on the horizontal axis is the local social inequity scores. And you can see there's a pretty clear relationship, an inverse relationship. As life expectancy goes down, LSI goes up. And here you can see on the left in Ohio, we have our life expectancy estimates, or YHATs, coming out of the random forest models. And you can see on the right are the local social inequity scores for Ohio. And that 30-year gap on the left, you can see that as you expand that up to a 100-point gap on the right, or a 100-point scale, you get a better sense visually of where places are not doing as well, or where they're doing better. And when we scale that up to the entire US, same thing. So life expectancy estimates on the left and local social inequity scores on the right. And you can see that the bright yellow are higher social inequity areas, and the darkest purple or going into black there, those are the lowest social inequity scores and the highest life expectancies. So we have these scores, as I mentioned, at the census tract level across all of the United States. And when we look at the random forest output, we can get a sense of what the top predictors are. And these are predictors that are important to the algorithm's accuracy. The indicators that or the information that we get out of the random forest tells us the variable importance, or VI. And we can rank those variable importances to understand what's driving the algorithm. And when we look at those VIs, the #1 predictor of life expectancy across the entire US is nursing home residents per 100,000. That's the #1 variable in terms of importance in 75% of the states. #2 is mentally unhealthy days per month. And that's an indicator of what I think we have called, deaths of despair. Tooth loss prevalence is the third, and I think that's a really important and interesting variable. It gets at diet, possibly drug use, maybe violence. It gets at help-seeking behavior, so whether someone is going to the dentist, and of course it's a poverty measure. Many people with Medicaid and Medicare don't have dental coverage, and that can make for a very difficult time actually getting dental care. A lot of people get dental care in the emergency room, and all they can do there is pull the tooth. So, and once you have lost teeth, it makes it difficult to eat certain kinds of foods and have certain kinds of jobs. So it is a very, there's a lot going on in that variable. Tooth loss is also related to smoking, and smoking is the number 4 variable importance predictor. I won't go through the rest in detail, but just to note that some of these are in the positive direction and some are in a negative. So number 8 on the list, foreign-born, the more foreign-born people, the lower the local social inequity in a census tract. So we benchmarked our local social inequity scores against 3 other composite measures of social determinants that are publicly available and in current use in the US: the Social Vulnerability Index, the Social Deprivation Index, and the Area Deprivation Index. The 2 in blue there, social vulnerability and social deprivation, have fewer variables, 7 or 8 variables, and the area deprivation has 17 measures included in its index. As I mentioned, ours has about 150. So you can see when you add more indicators, you do get a better variance explained in terms of our outcome. So that's shown on the left axis, the percent of variance explained in life expectancy at birth. The only state where we don't do as well as our comparison measures is Wyoming. But in every other state, we outperform those other indices. And across state, in the center there, you can see across all of the US, we explain about 2/3, 67% of the variance in life expectancy at birth with our measures. And our best performing area is the District of Columbia, where we explain about 3/4 of the variance. So I want to mention here that risk adjustment for social risk factors does not mean that providers are off the hook in terms of addressing social risk factors. Just like with clinical risk adjustment, if you adjust for diabetes with complications, that doesn't mean that the provider is not responsible for dealing with diabetes with complications. It just means that you're paying the provider for caring for that patient with those complications. It also does not imply that lower standards of care are acceptable for people with higher social risk. In fact, the opposite is true. What we want to do is not to unfairly penalize providers for factors that are outside of their control. We want to also avoid rewarding providers just because they have better off patients. So risk adjustment for social risk factors is intended to address health equity by paying providers more for seeing more complex and more at-risk patients. And our goals for this project are to help researchers control for social factors in analyses, to use those scores in evaluations, and we've done that on a couple of different projects so far. We are finding that the scores are performing very well in evaluations in complex models. One of the really wonderful things about having a composite measure like this is that you have a more parsimonious model, so you don't have to include multiple different indicators. You just include the one, and that captures everything that you're trying to get, where you're trying to adjust. These scores could also be used to target interventions to higher risk populations. So you can imagine if you have a population and you map their local social inequity scores, you can understand which individuals are at highest risk by targeting in on, the top 99th percentile or the top 90th percentile of risk. And also not just individuals, but communities, where you can see here's a community that has, for example, high infant mortality. So perhaps you target interventions in those areas based on delivering better interventions around infant mortality. And like with the tooth loss measure, we can really look at root causes and potentially inform policies to address those root causes.
Thank you for attending this RTI-sponsored session. From implementing innovative models to developing quality measures, to conducting large surveys to measure quality of care, to using data and science to make processes more efficient. We are proud to work with CMS and its many partners and stakeholders to enhance the quality of health and healthcare and reduce cost through improvement.